My name is Anthony Moorman. I work at Newcastle University, and the talk that I've been giving at the EHA 25 conference this week is looking at the outcome of patients with ABL-class fusions treated on a trial called ALL 2011, which is being based in the UK. So just to give you a bit of background about what ABL-class fusion is, these are a group of gene fusions that occur in a small subset of patients with childhood acute lymphoblastic leukemia that come under the overall group of BCR-ABL-like or Philadelphia-like ALL. And they are one of the groups that underpin this particular gene expression profile. Previous reports have reported that these patients have a high risk of relapse, that they are associated with a high level of MRD at the end of induction, and there have been sporadic reports that individual patients have responded to tyrosine kinase inhibition. Now, these reports are predicated on the basis that patients with BCR-ABL fusion itself, of course, these patients will respond to treatment with tyrosine kinase inhibitors such as imatinib and dasatinib. And so the logical rationale, but if these patients have the same kind of underlying functional consequence, i.e. the upregulation of the ABL pathway, these patients may also be responsive to these particular drugs and help improve their high risk of relapse. However, because the number of patients are small and the subset of patients with ABL-class fusion are highly heterogeneous, there have been no randomized studies to compare patients receiving a tyrosine kinase inhibitor in addition to their standard chemotherapy versus chemotherapy alone. Although we weren't able to achieve this precise randomization ourselves, what we did do in the UKALL 2011 trial is about a third of the way through, we started screening patients that had high levels of MRD at the end of induction for these ABL-class fusions. And because it took time to roll out across the whole of the UK, at the end of the trial, we've ended up with two groups of patients. One group that were prospectively identified and hence given imatinib at the end of induction, and one group that weren't. So it's kind of like a randomization of sorts. So in total, we ended up with 21 patients that had an ABL-class fusion. We only screened, importantly, patients that had MRD values of 1% at the end of induction. So within this group of slow responding patients, we found an incidence of about 12% in both B-cell precursor and TALL patients. So obviously this is not the percentage in the whole of childhood ALL, this is just the group that has slow responding MRD. So it does account for a reasonable proportion of these patients have a slower response to initial induction therapy. So among these 21 patients, 13 received a tyrosine kinase inhibitor, always imatinib in this case, very soon after the end of induction, whereas the control group, 8 patients did not receive any tyrosine kinase inhibitor therapy until after they relapsed. When we compared the kind of demographics of these two groups, we found that actually they were very concordant with it in terms of the sex, the age, the white cell count, and T cell status. There were no obvious differences between the two groups. Both groups of patients obviously had very high levels of MRD at the end of induction. Although our threshold for testing was 1%, actually in reality, many of these patients had MRD values of 20, 30, 40% at the end of induction. So they were very refractory patients. Importantly, it should be pointed out that none of these patients only received tyrosine kinase inhibitor therapy. It was always in conjunction with standard high-risk chemotherapy. But when we compared the outcome of patients that received the early TKI at the end of induction versus the control group, the relapse rate in the control group was significantly higher. So amongst the 13 patients that received imatinib at the end of induction, there were no relapses at all with the follow-up time that we have, which is about 2.5 years. 2 patients, unfortunately, did die of transplant-related mortality after their stem cell transplant. In the control group, 6 out of the 8 patients either were completely refractory and died, or had a relapse. So that's a very big difference between the two cohorts of patients. Obviously, the numbers are small, and there's a caveat that all patients had high-risk chemotherapy as well, and many of these patients went on to transplant. But these data, in conjunction with the sporadic reports previously reported in the literature, strongly indicate that the addition of imatinib for this small cohort of patients is beneficial to them. And there was no massive increase in toxicity associated with the addition of imatinib. Obviously, many of these patients did have high levels of grade 3, grade 4 toxicity, but they were receiving high-dose chemotherapy. So that's not necessarily surprising. So what we've done now is we've taken these results in our next trial, which is a pan-European trial called Altogether 01. All ABL-class fusion patients, all of them, will be identified at initial diagnosis and given imatinib from day 15 if they are under the age of 16, and at the end of induction if they are over the age of 16. And the rationale for this treatment change is what we're hoping to do by introducing the imatinib at day 15 rather than at the end of induction, is to reduce that MRD load that was observed at the end of induction. So we're hoping that, like with the BCR-ABL patients themselves, introducing imatinib earlier will have a beneficial effect much earlier on in their chemotherapy. So that's clearly the take-home message. So in the end, I'd just like to acknowledge all the many people that have been involved in this study. Although it's a relatively small cohort of patients, they were all treated in different centres across the UK. So it's been a real job getting all the clinicians to contribute data. And also, I'd just like to thank the patients themselves and their families that agreed to be on this trial, and in many cases receive this novel therapy in addition to their standard chemotherapy. Thank you very much.